G'day everyone, my name's Nick. I guess we should make a start. We'll leave the door open for maybe another 5 minutes and then close it as we get into it. So thank you all for coming along today to talk about assessment. So just a little background, everyone in the blue shirt is part of the Registrar Committee of ACRRM, so we're all trainees. This is an open door for the whole time of the conference for you to come see us and ask questions as you want. So before we start, I guess, do you guys need me to go down here? Oh, of course.
Yeah, if you want, there's a microphone.
Okay. I guess, we have multiple people in the room, so it's good if we talk about sort of ground rules. But before we talk about ground rules, I'd just like to acknowledge that the burden of medicine is large. And with the care that we provide in our rural communities, we are commonly defined as a doctor first and a person second. And sometimes we even personally define ourselves as that. When we fail an exam, and you are the only doctor in the community, you feel completely alone. You question your skills, you doubt your ability to do your job, and you doubt your vocation. Please know that you are not alone. I have felt this pain, and others here have too. Do not suffer alone. Please reach out to our blue shirts, to other trainees, to mentors, to your training officers. We are a community, we are your family. Please lean on us. So today we'd just like to give our registrar's experience of the ACRRM assessment. The reason we're doing this is to have productive and hopefully constructive insights and hopefully some tips and tricks to help trainees get through their assessments. Who is here? Well, everyone is here. We have our college assessment committee, we have educators, we have staff, we have trainees, students, and any interested stakeholders. I've explained all the acronyms apart from ACRRM, so hopefully that will help. The last thing is, in this space, I'd hope that we respect each other and this space. And as I said, if you feel that you need to link up and get support, please do, and come see us anytime. So the session today will be doing case-based discussions, multiple choice questions, and stamps. Dr. Sims, Dr. Ricciardone, and Dr. Vimbai. I'd like to welcome Dr. Sims to the floor.
Thank you. Okay. Probably people don't really know who I am based upon that name, so I might just very quickly start with saying, so my name's Dr. Kari Sims. I'm a dual fellowship trainee. I've actually completed my FRSCGP. I've sat all of my ACRRM assessments, so if you happen to see me around and you want to ask me some questions about that separate to this, then feel free. And I'm currently undertaking my advanced skills training in anaesthetics, and I'm based in Mildura in Victoria, but I'm originally from South Australia. So, case-based discussion. I do actually have a few notes. I wrote these on the plane. So case-based discussion is an assessment of clinical reasoning and application of knowledge in a clinical context. The candidate will need to demonstrate evidence of their clinical knowledge and how they apply that knowledge by appropriately assessing patients, formulating differential diagnoses, ordering relevant investigations, and applying appropriate management and follow-up plans. That is verbatim, word for word, from the fellowship handbook. So basically, what does that mean? The CBD is you showing that you work safely and competently in the job that you do as a GP every day. So really, when the case-based discussion can feel, I think, a little bit intimidating as to what type of assessment it is, but it's trying to get an objective assessment of how you work on a day-to-day basis. That's basically what it's there for. I did notice that there's been some recent changes for the case-based discussion to allow people that are in some more acute settings within the RFDS or acute medicine settings and how they can sit the CBD rather than being in the primary community training. I'm not going to speak to that because I don't have a lot of experience. So if you want particular questions about that, best to ask the guys that are here from the assessment committee. That will talk once I finish my little bit. The suggestion from ACRRM is that the CBD should be done post you passing your multiple choice questions. That's what they recommend, and there's a reason for that, because if you've sat and passed your MCQ, then the expectation is that you have the background knowledge to be appropriately working at a fellowship level as a GP, and that's essentially what they're testing. As you guys may know, if you've had a bit of a look, you need to submit 12 cases. You did something. So I just want to say, Nick did my slides for me because I was actually away, so I'm not really sure exactly how they all work. So thank you, Nick. And I'm also not really talking to them because they were done beautifully by Nick. So you have to submit 12 cases, and it says a medium level of complexity. It doesn't have to be hard. It doesn't have to be interesting all the time. Not everything that we do day to day in GP practice is really hard or really complex. But you still need to have continuity of practice, and that's what they're looking for. You need to have seen the same patient, ideally, 2 to 3 times, have continuity, have follow-up. And that's then going back and talking about, you've come up with your potential plan or your potential diagnoses, you've followed it through, this is how you've managed it, and now you've followed the patient up. Sort of a completion of a cycle of care within the cases that you're submitting. It's a good idea to choose your cases as you go along. Work out roughly when you're in that time period that you're going to sit the case-based discussion, and each week sort of do a little thing that goes, what cases have I seen this week, or what did I see today that I could maybe submit? There is a time frame limit. You have to have seen the patient within 3 months of submitting all of your cases. That can be your 4th visit, that can be your 5th visit, that can be the visit potentially, as far as I'm aware, a year after you initially saw them if you spent a significant time in practice. Not 100% sure on those finer points of details, but the goal is that you have seen them within that 12-week process. Best ways to prepare, to know exactly what the CBD is, not necessarily take everything from me, but to read the assessment handbook, which is what I reread when I was going to prepare for this, because actually it has some really good information on what is the case-based discussion, what are its goals, what are its testing, what are the domains that ACRRM is looking for when you're sitting it. I think when I sat this last year at the start of the year, and I remember talking to my medical supervisor, GP supervisor, about what are we going to do, and it was still a new form of exam for both of us. And he said, you don't have to have been perfect in your case. This isn't about you have done the best job as a GP registrar or as a fellow. That's really the level you're testing at. You actually just need to show that you have learnt something. I think, and it was said in the talk this morning, that we're not all perfect. Being imperfect is actually okay. I think what you're looking for when you're selecting a case is somewhere where you've learnt and you've had a journey, and you've maybe gone along with the patient on that journey. So it could be a hard consult, a hard follow-up, incorrect diagnosis potentially, but maybe the diagnosis you made initially was, it was not the zebra, it was the horse, but you ended up with a zebra. So that makes it more interesting, but it's not actually about having been right or wrong. The CBD tests why we do things. So when you choose your cases, absolutely your best way to prepare for this is go through them with another person. Read them, know them, talk them over with someone. Have someone else ask you some of those questions in the handbook. Have someone say to you, why did you pick this case? And you then have to go, in your prep, I chose this case for my CBD because I learnt this. I thought it was tough. It was an example of XYZ. I think when you do that, it's a really good idea to practice visualising the patient and the consult that you had. I actually found it interesting when I sat my exam for one of my cases that was selected, the examiner was asking me about the actual detail of my clinical exam that I had done on this patient. It was relevant to how it had proceeded, and actually talking me through, well, what happened when you asked them this or when you did something else. And I found that really useful because it made me visualise that patient in front of me while I was on the phone, because this is often done as a telephone exam. Well, I was visualising the patient in front of me and going over in my head how I run my general clinical exam in a consultation, and how that patient reacted. And there was a question about how they'd walked and gait assessment for Parkinson's for what they presented. I can't even remember now exactly what it was, but I remember that was the question. They said, well, did you look at this? And I was like, well, obviously, because I look at my patients when they walk into the room, and I thought about it. And so it was verbalising what it is that I had done as my day-to-day practice. That's sort of what this exam is looking at. What do you do daily? Why do you do it? Why do you pick that test? And how do you choose to order an ultrasound versus a CT, or order this particular blood versus that particular blood? I think there's another slide, because I think this is the bit I'm up to, the tips and tricks, but there's nothing on this slide because I didn't write anything. So yeah, it's here. So yeah, de-identifying the cases takes a hell of a lot longer than you think, just so you know. It really does. And I'll be honest, when I had to de-identify mine and hand it up, it was about the same week I sat the MCQ. The deadlines were really not great, but that's how it happened for me. Don't forget that names sometimes print in the header and the footer. If you print something out from, your clinical notes or something, be really good friends with whiteout. The ones that you just kind of the tape whiteout, and the other ones, because you have to find everything and you have to go over it, and you can think that you've de-identified the whole thing and then realise that you left one particular name somewhere. I'm not going to talk about privacy for the case notes. It's something that you need to think about as to where you're getting that. That's going to be very different depending upon where you work and whether you're taking notes from a hospital or taking notes from a private clinic. But yeah, de-identifying cases takes time, trust me. And maybe keep a copy where it's not de-identified and the copy that you submit so that you remember which one they're talking about. So yeah, prepping for the actual exam, pretend it's a chat with a supervisor. It's called an exam, and it is an exam, and it's done for a reason. But as I've said, preparing is practicing it with a colleague, one of your GPs that you work with, maybe your medical educator, one of your GP supervisors, one of your friends that's going through it. That chatting that you have, as I said, is really good preparation. But when you're actually doing the exam, just pretend it's more like that. It shouldn't feel too intimidating, because they're not looking at were you right, were you wrong, are you good, are you bad. They're actually looking at what was your thought process, are you meeting the appropriate thought process, are you practicing safely, are you making the right sort of decisions that you should be making as a fully fledged fellow, because that's the standard that they're adhering you to. It's okay to have a light bulb moment in this exam, to not be perfect. You actually might learn something from the questions that you get from your examiner. I actually did learn a few things as I came away. I was like, oh, when I thought I'd picked these cases and reflected on them, I had actually come away from the exam and learnt a little bit more as to why they were good cases, and that's actually a good thing. The exam is based on the notes that you submit to ACRRM. You should always have good notes. That's just a given in the practice of medicine. You get really busy when you're working in a GP practice, when you're working in a hospital, and your notes usually are where that starts to fall down. So your notes will jog your memory for what you're going to say. You should have good notes. Maybe if you don't at the moment and you're thinking of doing the CBD soon, learn some little shortcuts within whatever medical program it is. You put in 3 letters and it suddenly drops down something else. That's always the way that you do something. But definitely have good notes that you're submitting. Expect the odd curveball question in the exam. I definitely got one. I got one that asked me about the pathophysiology of pertussis. I don't know the pathophysiology of pertussis, I'll be honest and say that I don't know, I had no idea. I learned what it was though, which was quite good, because the examiner knew, and it was obviously an area that they were interested in. But yeah, so expect the odd curveball question, and don't let that fluster you, because as I say, it's not trying to work out right or wrong. It is shades of grey to a degree in this one. Each assessor is different, each case and patient is too. So you submit 12 cases, you're examined on 6, and you generally have 3 different assessors. So each time you do one of these CBD exams, it's a staged exam, it will be different, and that's okay. You have to have 5 of your 6 that reach expected level of a fellow of ACRRRM. Again, all in the actual casebook, the handbook, sorry. Yeah, don't be too scared. If you're well prepared, you know your cases, you've sat there, you've prepped it, you've thought about why you did what you did, and you weren't just a robot in that particular one, you have a pretty good chance of passing. The most recent public exam report, I think that's the one after. Yep. There's another one, since Nick put this together, but this is the one before. So this was a pass rate of 79% between January 2016 and the 3rd of November 2017. There's a 72% pass rate for the start of this year. And since 2016, when this first came in, And at that point, at the start of 2016, it was a very new exam. 68 to 80% of candidates sitting the exam have passed. So I think overall, really, although it's an exam and that four-letter word makes it sound really scary, so I've tried to hopefully make you aware this is really your opportunity to explain to the college and the assessors why you are the type of GP that you are today. That's basically all I'd prepped.
Thank you, Kari. I'll just run with this roaming so that our people who are remote and rural can hear the questions that you have. Before we take questions, I might just ask the minds of our...
Take questions
okay. First.
So answering questions is not just me. I'm just one person, but also we do have some people here from the college that can help answer questions if I say the wrong thing or get stuck.
One tip is you do get to choose your cases.
You do, absolutely.
So choose your best notes.
Yeah. You should always have good notes. Yeah, choose your best notes.
Yeah.
As long as they fit, there is, and I didn't say it, again, it's in the handbook, there is the domains that you have to meet. And radiology, child health. I think mental health is a core domain. One of them is a core domain. I think it's mental health. Someone's going to prompt me on that, maybe.
One other.
Sure it is. Yeah. Yes.
But they're not, it doesn't have to be just on pathology. So if you've got other domains within that case, if you had a mental health consultation or something about the mental health within that consultation, that can just be additional to that. So it doesn't have to be just single domains within each of the cases either, so there can be a number of them represented.
Which is a key point. I mean, you might have the child that meets your paediatric, but in the same you did an X-ray investigation and that's your radiology because they presented with something. When you're choosing the domains to meet your cases, think broadly, pick as many domains as you can make fit. If you submit a case that doesn't meet what ACRRRM are happy with, they're going to let you know and you're going to get a chance to submit another case.
We have a question?
I was just wondering, like when you're seeing your patients and you don't obviously, in primary care, don't write in their past medical history and their meds because it's already in your system, should we include like a clinical summary page or should we put that into the case front cover page, like their past medical history and meds?
My answer to that would be include what you think is relevant to make the case most appropriate for what you're selecting. So if you're putting in your notes and that's maybe to do with a drug change for a mental health patient and you're choosing one and you've seen this patient over a number of times, then it might be an idea to come up with a summary page that says these dates they're on that drug and it was ceased because of, so I don't think there's a hard and fast rule. My answer would be submit what you think is needed to make that case fit from start to finish, from when you first saw the patient to the end. And it might be that you start, your first bit that you submit is summary from every person that saw them for 10 years before me and what I'm dealing with. But target it to why you're submitting. If it's diabetes, focus on that and ignore what else has been. Did that answer your question? Yep.
Thanks, Dr. Kari. We'll move on. One little tip, maybe a round of applause.
That's fine. Thanks.
One tip or trick is it might cost you a coffee, but if you ask your receptionist nicely, they can de-identify and then you can just check it. Next we have Dr. James.
Might need more than a coffee.
Might need more than a coffee. I'd now like to welcome Dr. James up.
Hey everyone, I'm James, the chair of the Registrar Committee. We are going to talk about MCQs. So, for many of you, we'll go back. For many of you, the MCQs might be your first assessment. You might have done your CBD. It is recommended before the CBDs and after your MSF. MSF it's probably not going to be a tough exam for you. So for the MCQ, this will be probably the first time that you're sitting in assessment and paying money and thinking about the end of your fellowship. I think it's really, whilst it is the first one, for some of us, it may be your most challenging one because of the type of learner and the type of person that you are in an examination. And I think often the MCQ is seen as, there's like stamps, that will be really hard. But there'll be a subset of people, and I think probably probably fell into that category, where MCQ questions are not the best way of getting out my knowledge. And I think the first thing to remember is you've got to acknowledge the type of person you are and then let it go. If you've struggled with MCQ questions in the past, in all your, everyone's done heaps of MCQs, you're probably going to struggle this time round. And some people seemingly study for 3 weeks and pass, and you're like, oh my God, how come I have to work so hard? So I think that's the first thing, is understand that this will be, for some of us, it'll be easy, for some of us, it won't. How you do it is, and when you do it, is different for everyone. Some people will do the MCQ first, early on, after 12 months of PRT. Some people will do it smashed in with stamps. You have to kind of have a think about what type of person you are and your timing, and kind of, if you're going to do the MCQ and stamps together, then you are going to have to make sure that you have nothing else in your life, because it's going to be, it's not true, you're going to have to work, that's going to be a much different examination style. And some people do it and some people succeed, they smash it out in 6 months. But some of us will not be able to do that. So I think it's really important having a think about. I think doing it early is a good idea to get ourselves thinking about doing the exams and not being stuck, in your last year and you've got to do MCQ, CBD and stamps, because one, you might stumble. It's 125 questions over 3 hours. And just like any multiple choice exam, there's a style. So there is there will be a STEM, a clinical question, and 5 options. 4 now. Oh, is there not 5? Oh, okay. That's great. Oh, so it's all right. There you go. You've just increased past. There you go, 4. I swear it was 5. So 4. All right. So that's, if you go in that knowing that that's what you'll be going into. I think it's important because a lot of the practice questions that you might do won't have quite an extensive clinical STEM. So you have to acknowledge that in the timing of your when you do the exam. So you can do it at a test centre or local. Surprisingly, this might be one of the toughest things to sort out because it's on a Saturday. If you can't get someone to be your invigilator on a Saturday, then it's going to be very hard to do it locally, and this can be very stressful. So when I first thought about it, I was like, "Oh my God, I'm going to do it locally," and it was so stressful to try and work out someone to come in on a Saturday, and it was just easier to go to a test centre. So think about that early because.
James, can I just comment that we've actually moved it to a Friday.
Oh.
So the last MCQ was on a Friday because we did realise.
Oh, you don't need to run to me. I'm loud anyway. You didn't hear us in the pool last night, did you? No. Sorry?
It's the people remotely.
The people remotely. Oh, sorry. We've moved it to a Friday because we did hear that it was difficult to find premises and invigilators for a Saturday. Yeah. So, yeah, great. Yeah.
I think the important thing is that you are the type of person that you are. If you're going to stress about whether that person is going to not be able to be there, or that your Wi-Fi is a bit sketchy wherever you are, and the test centre, at least you can kind of let that go. So that's kind of.
Where are the test centres?
So they vary. Where were the last test centres?
We've got a big test centre in Brisbane, and then some of our other universities support us. So sometimes we have one at JCU, we'll have sometimes out at GPTQ as well. So it depends on the centre at the time. There's a number of them listed on our website though. One other thing, James, and what you're saying there is absolutely right about your internet. We actually encourage you to have 2 different types of internet, 2 different opportunities for the internet to fail before you before you sit that exam. So if you've got Wi-Fi and a LAN connection, that's really helpful. Sorry, James.
No, that's.
Not butting
No, that's great. So I think probably the biggest decision you'll have is whether to sit it with stamps, and I think this is kind of something that. it really depends how much time you have. So I think for MCQ, if you're going to study quite hard, like 3 months is a pretty good, like if just you're doing the MCQ and then you're going to will be 3 months of quite hard study. If you do it with stamped, you got to add on that other 6 months. And I don't think, in my opinion, you cannot you might get some crossover, but stamps is a different type of exam. So, that's significantly more study. I think, so we're into tips and tricks, and I'm not going to teach everyone to suck eggs. We've all done MCQ questions. But I think the important thing is that to break it down, that it's not just about the studying for the exam. So you've got to do some good preparation, obviously, and everyone has different how they kind of study. I'm very much of someone that it should be efficient study. And I think that with MCQs, doing like for like, so doing a lot of MCQ practice, is a great way to kind of get you in the test mindset. There are a lot of kind of practice programs out there. Probably the better one that has a lot of information, a lot of questions for a cheap price is like Past Medicine. It's UK based. Obviously, that's not the only thing you can use. You have to think broad. You'll have to study things like all the ALS and emergency guidelines. You'll have to study saving something like DermNet, the New Zealand DermNet for derm, and try out a few different MCQ practice tools because they give questions in a different way, and also remember that a lot of the practice tools might be from other countries. So you've got to be. It's all about using its breadth of different study techniques. Your method of study is so how you're going to break it down. So everyone will be different and you can ask different questions. Sometimes practicing a few MCQs, seeing where they kind of some of your weaknesses are and focusing on them. One of the things that I found, and it's probably not should be said in this room, but was the most helpful was previous people that had done the exams, what the approximate breakdown of questions. Because one of the things is that you go and they go, study from the domains and study curriculum. And that's great. That's definitely true. You should definitely look at that. But then you have to kind of know what's the biggest bang for your buck. So if you don't work in an area without Indigenous health, you're going to have to focus on Indigenous health. There is quite a few questions on Indigenous specific things like rheumatic fever, like post-strep glomerulonephritis, they are high, those kind of questions come up. So that's important. If you don't, there are a lot of questions there's questions on palliative care. There's don't forget things such as professional development and ethics. There's always a couple of questions like that. But actually, until I kind of saw that kind of breakdown, I didn't really kind of any idea of how the domains work. So I think kind of asking previous people and asking them, what kind of questions came up? There was a lot of questions there was a lot of kids questions. And it might be that there was 6 or 7 when they thought there was going to be only 2 or 3. So it's really good to kind of work out kind of the breakdown. And there's plenty of those kind of breakdowns after the exam on assessment preparation websites, and it might give you a bit of idea of how much time to spend. I think kind of finding your own technique for reading and answering the questions. I think a lot of people who fail probably can put it down to bad reading of questions or not really actually picking up the important parts of the question. So for some of you, it might be highlighting the word on the computer or reading the question totally first before answering the question. You've got to kind of work out where you kind of go wrong. There's a lot of research on, does your first answer end up being the right answer? Should you change your answer? Look, you've got to kind of find a way that works for you. And really, there will be times where you go, these are the 2 best answers, and you kind of, in the end, it's the best answer. So some of them might be more right. And also remember that you can run out of time. So remember that in the exam, you're probably going to take longer than you did practicing. So you need to have good test management. And just like all exams, and we don't think about it as much in MCQs, you've got to kind of have a bit of a think about your brain. So in the fact that, have you been practicing for 3 hours hardcore. Like, you know, have you done 3-hour test conditions? Because this might be the first time, because you've done like an hour and then you've had a coffee and then you've done another hour. You might be someone that kind of dies off at the end. So understand that. I think the MCQ of all the exams is probably, there's no real kind of surprises. Like the stuff comes up from the domain. It's all about kind of getting that information into your head, a lot of it, and being able to like basically have, you've seen a lot of the questions before, because there's only so many questions they can ask in general practice type questions, and they'll ask it in certain ways. So if you do a lot of practice of exams, I think that a lot of these questions, like, oh, I've sort of seen this question before, like they're asking about, I don't know, like ALS, like, you know, so I know that. Or like, oh, I know this is about recognizing meningitis. Like, so I think of all the exams, the MCQ, if you put in the prep, you should hopefully will have a good outcome.
Thank you, James. We might just take one question before we move on to the stamps. There's a question over here. The other thing is, don't spend too much time on unicorns. I think, you know, we're general practice doctors and all the general practice stuff.
You mentioned past medicine. Just wondering, I've heard of Dr. MCQ. Would any of you guys recommend that's worth trying, or do you have any other good practice resources?
Yeah, so Dr. MCQ is Australian based, but they don't have many questions. So, and it's more expensive than the past medicine kind of, and there's BMJ as well. So,
I was going to add to that, Romeo's pretty good for
oh,
things
yeah,
like
sorry,
Q
Romeo,
fever
yeah.
Could you just get a round of applause for Dr. James, please? Next to the mic is Dr. Vimbai.
Hi guys, for those of you who do not know me, I'm Vimbai Kapuyav. Hopefully you can see me. I've been a member of the Registrar Committee for a couple of years, and I'm now a fellow, an ACRRM fellow with AST in Pediatrics. So I'll be leaving the RegCom this year. So if anyone is interested in joining RegCom, it's really a good idea to get registrars to actually, you know, represent the fellow registrars and get us doing stuff. Thank you, Nick. And so I trained in the Northern Territory here. I did my training in Katherine with a great training organization, NTGP. And yeah, training in the Northern Territory was really good. So if anyone's thinking of coming up here, it's a great place to train. We're going to talk about stamps today, and it gives a lot of registrars quite a high level of anxiety. But I think the most important thing is being able to practice, really. This is mainly from the assessment handbook, which, as Kari says, has got everything that you actually need to know about the exam. It can usually be done 24 months after you've started your training. There are 8 scenarios with 8 different examiners. Usually you get a 10 minutes pre-exam prep time, and then between each scenario you've got 5 minutes. You don't actually have patients present, so you sit in one room and the examiners move from room to room, so it's more of a Viva style as opposed to what RACGP has. And so it's really important for the registrar to be able to change with each time the examiner changes, the scenario changes, and remember that each different stamps question is a new thing. So often people, if you've had a bad experience in the one station, when you move to when the examiner changes, you might still be flustered, but just try and get on with the next question. There are usually 2 sittings a year. There's a face-to-face in Brisbane, and now they've added Sydney, which is great. So there's more opportunities for people to do their exam. And then there's video conferencing in the second semester. Remember to always check your dates of enrollment, because a lot of people say they missed the enrollment and then they can't do their stamps, and you have to be very clever and know when you can enroll and make sure you enroll in time. It is a costly exam, so when you do it, you want to do it right the first time, so you really need to prepare. It looks at safety, so making sure you're able to be an independent and unsupervised practitioner. Looks at your clinical reasoning, and make sure that you understand the context of your geographical site or logistics of working rural and remote. The very big thing that people are always stressed about is Stampsville. So you need to know the community profile. This is available on the ACRRM website. I think this is from 2015. They have the same Stampsville for a few years and then they change it. So you really need to be very familiar with what is available in Stampsville so that in your exam you don't talk about taking the patient with a head injury for a CT scan when there's clearly no CT scanner in Stampsville. So you really need to know what's in Stampsville. So for the actual exam, you need to be able to read the STEM and look for any clues that may be there. You really need to use the first 10 minutes well. Usually people try and, some people use templates of what they need to remember for different types of cases. Some people like to look at the whole exam. So in that first 10 minutes, you're allowed to look through the whole exam, all the scenarios, and then you're supposed to also be preparing for your first station, such that when the bell rings, the first examiner will come in and you start the exam. It's good to have a template so you can try and structure your questions, but you never know what they're going to ask. Some people like to think ahead and wonder what is going to be asked, but the reality is they can ask anything. You need to know key emergency flags and remember to look at your time management, because I think a lot of people run out of time. Sometimes you get to maybe the second part and then the bell rings, and if you don't finish the question, you've pretty much not completed the case, so you likely won't pass that case. Very important to listen to the examiner, because sometimes people start answering the wrong thing. They're not listening to what the examiner said. And remember that if the examiner prompts you, you're probably going in the wrong direction, and that's not a bad thing if they prompt you. But obviously, they shouldn't be prompting you all the time. There's 5 areas of grading. So looking at the overall impression, your ability to have a management plan that's appropriate, and then defining your problem in a systematic way, communication, and then very importantly, flexibility in response to new information. So they usually do have some sort of a curveball in the question. Do not be flustered by it, but just try and keep your calm and think through what you're trying to answer. It's really good to join some sort of a study group or have some study buddy. ACRRM does have study groups. There's also a virtual classroom available. Cost for the ACRRM group is about $895, so it is quite costly. Some RTOs do offer study groups, such as my RTO, and sometimes you can form your own study groups. So there is ACRRM Registrar Facebook page. If all you ACRRM registrars are not on it already, you should join, because that's a good way of meeting other registrars as well. And then you can connect and form groups amongst yourselves to try and get your studying going. ACRRM also has got a mock examination. It's usually in Brisbane or via video conference. And again, it costs about $1,000. But there are limited spaces, so it's important to know about that and book early if you want to join that. So start studying early. I'd say about 6 months before is a good time to really get into your study mode for stamps. It's important to be very familiar with your primary curriculum and your ACRRM domains. Romeo is really good for studying. There is an ACRRM recommended reading list in the assessment handbook, and also looking at your ACRRM clinical guidelines as well. Each time you see a patient within your clinical practice, it's always good to think about it, what if this was a case for the exam? And if you do that every time, it actually helps you with your studying. Always good to get your training supervisor to help you and maybe even test you. And it's really good to try and write your own stamps questions as well. There's different areas, obviously, within the primary curriculum, but if you, for example, have a woman, a fertile-aged woman, always think about STIs, pregnancy, contraception, cervical screening, breast screening, that sort of thing. Always think about it. Pediatric, don't forget about immunizations, growth and development, and also thinking about social situation for pediatrics as well. Adolescents, we always talk about HEADS assessments. Men's health, the usual prostate checks and that sort of thing. Elderly health, thinking about, power of attorney services. There's a whole range of things to look out for elderly. Mental health, always think about risk assessments. Emergency scenarios, always remember your ABCDs, but remember not to just say ABCD in the exam. You actually have to state what it is, okay? Chronic disease, think about GP management plans, team care arrangements. It's always good to mention that in your exam as well. Public health issues, always think about Indigenous health issues. General practice billing is something we don't really talk about a lot, but I think it's really important as a general practitioner, obviously, and so try and get more familiar with being able to talk about it even in your exam. Mandatory reporting, fitness to drive, and safety. Right, so those are the main things that we'll be looking for.
Thank you very much. I think Vivas is a new format for me. I hadn't done it at medical school before, and people say, and I did it, if you can get your supervisor and record yourself doing the case, would you say that was effective?
Yeah, I think that's actually very good. Even when you're practicing with your study buddy, maybe record how you answer. It's actually good to listen to yourself as you answer, and then you start seeing all the ums and ahs and things that you sometimes say that you don't realize, and then, working on how to improve that as well.
Any questions, comments, thoughts? Yeah, of course.
My comment is absolutely practice. You really need to be practicing in that 10 minutes. Doesn't really matter what the scenario is, what case you're doing, but practicing answering something in a logical, consistent way in 10 minutes. So 100% practice with somebody.
Oh, sorry.
I was going to add to that, the big thing with stamps is it's a very broad exam. So you may absolutely smash, if you've got a Transcog Advanced or you're an EM Advanced skill, you may smash those stations, but you have to really make sure you don't forget those areas that you probably feel really uncomfortable in. So making sure you actually get your, if you're an anaesthetics, getting your Transcog friend to do the O&G stuff and not letting them just practice all the O&G questions, because that'll be what you want to do, because it's what you want to feel comfortable in.
I think the part about having a study group, one of the things that I think is the most important is that they're different people. And remember, there's different examiners. And whilst all the examiners are standardised, they're it's good to be able to see that some people will prompt you early, some people will prompt you late, and you have to be ready for that. So practicing with different people gives you different examiners, so you can kind of not be surprised by an early prompter or a late prompter. So that's important too.
So I'm a standardised examiner. so I'm a standardised examiner on the primary curriculum stamps. And one of the common mistakes that we see people make is reciting back the facts that we've given you. What we're looking for is the processing of those facts and an assessment and bringing it together. And so as an opening response to the question, if you can say something like, this is a case of potentially serious paediatric trauma, okay, is much better than saying, well, I've got a 6-year-old who's fallen off the first floor balcony and might have a head injury. We've told you that in the STEM. So if you are able to process it, when you read it, that's what you think. This is potentially bad trauma. Tell us that. We want to know what you're thinking. Don't waste time waffling. Some people seem to use waffling as thinking time. It's a waste of time. Tell us what you're thinking. Tell us the facts. Tell us what you're going to do with the patient, because that's what we want to know. How are you going to manage this patient in this environment, in this situation?
Sorry, Jeremy, another declared examiner. Remember, the key thing we're wanting to know, are you working at a fellowship level? So don't treat it as an examiner. Treat this person with you as a colleague. And so have a clinical discussion with a colleague. And that sort of changes your mindset in terms of, the way that you talk to this person and the fact that you're actually working as a fellow and not as a registrar.
one of my friends struggled with that, and they actually put a little statement on the mirror for the 6 months they were studying for the exam. Say, I am an ACRRM fellow.
And as a no longer registrar, I'm an examiner as well. It's a giveaway. One thing that's really important is to make sure that this patient that you're dealing with in each STAMPS case is in the community. Don't forget they belong to a community, and the community's there both for management and also for support. So if you keep your eyes wider open for each case, it makes it a lot better when we hear people say, and we'll bring in this aspect to this, and we'll bring in these people to help or whatever. So keep the community in mind with each case, and it'll be different for each one.
Thank you. Of course.
Now there's the non-standardised examiner.
Yeah, my name's Tarun Sen-Gupta, so I'm chair of the assessment committee. This has been gold. Like those tips, that slide and the one before and others. So there's so much helpful stuff there, and I think by registrars, for registrars, thank you to the committee and Alison in particular for putting this together. Really appreciated that. I want to give you a couple of perspectives from the assessment committee point of view. So I chair the assessment committee, and there's a lot of governance behind the scenes. Everyone groans when we say governance, but that's how we ensure quality, standards, safety, fairness. That's what we're trying to achieve. So we're trying to achieve an assessment, a fair result. Pass the people who deserve to pass. We take no pleasure in not passing people, but that's our responsibility to you, to the profession, to the community. You know, we take no pleasure in that decision, but we have to make the fairest decision. And we have a lot of literature on this. You know, we sample widely. So we use an MCQ. One of the reasons you use it is you sample lots and lots of cases. You sample thinking, you know, clinical reasoning in CBD. You sample what people actually do in practice. Lovely advice from Kari. You don't have to be perfect. Tell us what you do. And John or, you know, any of our colleagues around the room wouldn't hesitate to go into a STAMPS exam tomorrow or a CBD exam. Well, maybe not tomorrow, depending on whether they have a big night tonight. But in general, they would sit and do it, you know. But back to the governance. So there's an assessment committee. We have a registrar rep on that. The current rep's right in front of me. A former rep's just over there. Their voice is so important. There's usually an overseas trained doctor or two on that committee as well. We try to be diverse. So their voice is really important. Michael came to our recent planning day. There is a team of people behind the scenes at ACRRM working on this. Karen is the assessment manager. There's also a general manager educational services, Steve Lambert, who's also here, also wearing an orange shirt. There are medical educators. There's other education staff. Each discipline like STAMPS, CBD and so on has a lead medical educator and case writers. And some of those are around, and if you knew the work that they put in, you know, they turn themselves inside out to provide a fair result and as transparent as we can. And the feedback we've had through the Registrar Committee, I think, has been really useful. The public reports, trying to put information out there about what we're trying to do. So that's been very useful. There's also a board of examiners. So a separate set of people actually review the results and make decisions. De-identified results. We don't know the names. We declare conflicts of interest and so on. We don't know who we're talking about. We look at the results and make a decision. I'm on that, but that's chaired by David Campbell, who's also here as Censor-in-Chief. I'll just focus a couple of things and happy to take some questions. You know, good notes, that's a given in the practice of medicine. The preparation for these exams is really practice good medicine in your context. Demonstrate your ability to practice it in other Australian contexts, but good medicine. So the curriculum walks in the door. By all means, you focus on gaps, you know, the things you haven't seen, but the curriculum walks in the door. Get really good at the patients you see, think about them, think about, you know, those curveballs that someone referred to. There's a couple of people, those curveballs are actually what happens in real life. We all see them, you know, unusual things happen, patients surprise you and so on. And this list and the previous one about the thinking broadly around it, again, that's what good doctors do. So good doctors are, you know, you've seen the patient with asthma, but you're thinking about acute asthma, but what's going on at home? Is there a family history? How do I follow up? Are there allergens in the environment? And all of that stuff's there. It's not going to come out every time, but it's all there. Efficiency was alluded to. So we're trying to be efficient in, say, a 10-minute stamp scenario. Can we collect as much information as possible on the candidate? In return, can you demonstrate as much as possible? So being efficient with your dot points, a patient with an infarct, I would do these things initially, then I would do these things, then I'd think about this, and so on. So that kind of structure I think is really important. Comment was made, MSF is not so tough. That's true, but there's a lot of information and multi-source feedback. And we know, for example, that people with weaker MSF scores do less well on stamps. We're analysing that in more detail now, but Karen and Steve are presenting a session on Saturday, I think, looking at what we can learn from MSF. So don't regard that just as a thing to get through and then move on. It's actually assessment for learning. There's a whole bunch of data there on feedback in your practice. How can you use that to be a better doctor? Because that's the aim of the game. We ran one of these sessions, I think, at Wonka and Cairns last year, and a couple of your recent graduates said, it was the multi-source feedback that really helped us change our practice. That helped us get better at our practice. They're probably the main things I wanted to say. Oh, look, the other thing is, if you're given advice, please take it. People give advice for good reasons. You advise your patients about certain things, you want them to take it. And people are not saying that because they're bloody-minded or rigid or whatever. We've got some evidence as to the order you do things and what you might need to do. And if you, for example, got some MSF results and they were in the weaker categories, you might be better off to focus on getting your practice better, and then your stamps result might be better. So, and we are having this debate, and the registrars are involved in that. To what degree do we say you must do it this way versus here's our recommendation? So happy just to take other questions.
Any questions for Professor? No? Yes.
Oh no.
We've got a young medical student here. Question?
Yeah, I'm really nervous.
He behaves like a medical student, I can tell you.
As a supervisor and a practice owner, we often get registrars wanting to take big chunks of time off studying for exams, and that can disrupt service delivery, and it can be challenging to be a workaround. I'm just wondering what your advice is about taking large amounts of time off, given that what we're hearing today is that you're testing people's ability to do general practice or to work in their environment. And one of the things I've often said to my students is, you can learn more from just keeping on seeing patients. So taking large chunks of time off, I've always sort of leaned away from, but we've supported them when they've asked for it. Just interested in your actual thoughts around that.
I'd deflect that to the registrars or people who've done the exam recently. My general advice, John, my general thought would be the more you see patients and think about it, the better. But of course, if you're in a very high volume practice, say if you're in a particular situation where you're getting lots of experience but not much learning, that's an issue. So I think one issue depends on your environment and also your circumstances. I'd take comments from anyone.
I think there's a sweet spot.
Actually, just you come use the mic.
I think there's a sweet spot with registrars that fail sometimes is you can either be in a position where you're overworked and you're seeing too much and you're not sleeping, you're not getting that time to study, but if you're also not seeing the breadth of medicine, or if you're working in an area that's not truly kind of that regional, rural, or remote where you will have to deal with all things, or you're able to defer to, and I've got colleagues who don't do pap smears, that kind of thing, or don't do women's health because we've got Dranscog, so they can. So if you start getting into that habit early, you'll struggle when it comes up on the exam. So I think I like the comment of, working and the curriculum comes in the door.
I think it'll really vary on your style of study as well, and it'll vary on the exam. So breaking it up, MCQ versus stamps. I think with stamps, I didn't really take much time off, but I highly recommend people go to the online face-to-face courses. For example, pull out your topic report. It's got a trauma question 1 out of 8 every single year, and you think, well, what are you going to do for that? Do an emergency trauma management course for that, and you'll nail that topic. But I really advocate for staying in the clinic because you will learn cases. And Vimbai gave some really good advice about, imagine this was a stamp scenario. So yeah, you might have done it 75%, but think about if you've got a gap on your next, before your next patient comes in, and think about how you're going to fix that other 25%.
Yeah, I'm actually just going to agree predominantly with that. I think if you were looking at which exam needs a little bit more time off before, it's probably the MCQ. But that doesn't even need to be much more than maybe the last week before you sit the exam, because that allows you should have been studying anyway, you're seeing the patients and learning on the go. You should always learn on the go. But you do need a couple of days before the MCQ, I think, to get yourself in that mindset and to take yourself away from the practice and whatever's coming through the door next. 3 days would probably be enough for some people. Some might need a week. I think a bit more than that, and you're losing that learning opportunity. I think with stamps, it's learning, taking the cases that you've had, writing your own case from that, practicing it. You should be able to be working and still doing that. But as Michael said, if you're in a situation where you're sort of in a bit more of a specialised practice, you might need a little bit more time off just to remind yourself of the general area. But I think you learn most when you're working, but you do need to recognise if you need a day or 2 days or a week just before an exam to focus on that. Case-based discussion, I actually sat my exam in the middle of a consulting day. So I consulted, I had about half an hour before, like I took about maybe 2 hours or so off in the middle, like that middle block of the day, and I sat my exam and I went back to consulting in the afternoon. That seemed to work best for my practice and that worked best for me, but everybody's different.
Thank you, everyone. That's it for the session, except...
Sorry. That was really great. Thank you so much to all of you for contributing. There is a lot more on assessment happening throughout the conference here, and I would encourage you, if you are sitting assessment, if you haven't passed assessment yet, to come to each of those sessions. We've revised and reviewed and got some really good content in all of those sessions that are coming up. So it's different to what you will have seen before. It's not a regurgitation of the assessment handbook, which I know you've all read. So I'm just going to give you these times and hopefully we'll see you there. So following this session here, we've got the beautiful Lucy Walters delivering a session on, and Denise as well, apologies, on doing your AST project. So if anyone's doing a project, please stay and listen to that great information that we probably need more of on our website and in our handbook. I admitted that. Okay, tomorrow we've got ins and outs of case-based discussion. So Elizabeth Dodd and Emily Moody will be doing that session tomorrow, 10:30. So please come along to that. Here she is, the beautiful Emily. Yay! Emily's actually starring in a few of our productions in the next few days, so we'll give her a Grammy at the end. Anatomy and physiology of stamps. So please come to the stamp session. Same thing tomorrow, but 2:30. No, sorry, I think it's actually a bit earlier than that, 2:15, something like that. Just check on your program because we did get 2 different times there. It goes for about an hour and a half. There's going to be a role play in that session and lots and lots and lots of information and statistics, so please come along. MCQ on Saturday, 10:40 till 11:40 with Emily again. Once again, some more information, particularly on the context of the exam there. And Peter Arvia will be here. Does everyone know Dr. Peter Arvia, who's the lead for our emergency medicine stamps? He's going to do a talk on Saturday at 1:35, so please don't miss that. It's also in this room. And then, as we mentioned earlier, as Tarun mentioned earlier, the MSF talk, so that'll be following that in this room as well on Saturday. So please check your program and prepare. Thanks, Nick.
Thanks for all those things, and really get along to anything that's coming up that interests you and get involved. As you can see from today, through 2 of our 3 assessments are communication heavy, and multi-source feedback as well is a communication heavy thing. Through your communication and feedback, we've been able to do semester reports on each assessment. Through your communication and feedback to your supervisor, so you can individualise and tailor what you need to do for each exam. The communication is important for you to work out your own pathway in this space. Blue shirts, orange shirts, we're around all this conference to answer any questions, day or night, not after 12. Thank you so much for coming along today, and hope to see you at the conference later.